role of a nurse. Many years ago, I looked up what the definition of a nurse is. And a nurse is a caregiver for patients and helps to manage the physical needs, prevent illness, and to treat health conditions. But then again, we do that all the time. But what is a specialist nurse? The specialist nurse works in the specialist area and spends time learning about the disease area. And I mean learning about the disease area, understanding what the disease is, where it's coming from and where it's going to, and is dedicated to caring for the patient and the family. Next slide. That is something that I always believe in, is that the nurse is there to look after everybody in the family. But then again, a nurse must also look after themselves. The key is, as I said in the last slide, in the last meeting, ITP is managing the psychological stress and the physical stress. And my role is, as a ITP nurse, is to help the healthcare professional manage ITP patients by providing ITP education. And I've discussed this all before, and I seem to be repeating myself. And we provide support. We train patients on self-administration. We train patients on their medication. And we discuss all the treatments that the patients need and their side effects. Next slide. Sorry, I didn't realize it was repetitive. Next slide. Before 2010, there was only a research nurse involvement with patients. In 2011, the TPAs were licensed for use, and unfortunately or fortunately, all the management of the ITP patients were devolved to the nurses in the clinic, in the hematology day unit, to the CNSs in the malignancy or the hemostasis clinics, where the nurses discuss the TPOs with the patient and ensure that the patient is informed on the medication that the doctors were going to prescribe. Usually the medication was prescribed by the hematologist, and the nurse ensured that the patient had weekly blood tests. And then the doctor decided on the dose changes, and the nurse implemented this with the patient. Next slide. As patients needed more involvement about their condition, my nursing role is involved to ensure that they're looked after comprehensively and that the patient has an advocate in their say with their treatment. So I became involved in the education of the patient on the disease. I got involved in the ITP Support Association to become more knowledgeable about the patient concern. I became involved in hematology group to further my involvement in ITP. I then also had, because I was running to the doctors every 5 minutes to give me prescriptions and sign prescriptions on what I was doing, I did the non-medical prescribing course and became a recognized ITP nurse consultant. Basically, I became the nurse consultant when Dr. Drew Proven resigned, and there was not a single ITP consultant in the Royal London Hospital, but the patients needed still to be looked after while they were employing another consultant to take over the role. And I was generally involved with the registrar making decisions on the patient, but because I was a prescriber, I could prescribe with a consultant standing behind my shoulder that didn't know what they knew ITP, but they didn't know the disease myself. So they actually allowed me to do look after the patient because they felt that I was quite good at looking after the patient. Next slide. You must understand that I don't work alone. I work in conjunction with the consultant. The consultants still have the responsibility for the patient. I can't just make any decisions by myself. I can manage the patient. I can initiate some of the treatment, but everything that I do is in conjunction with the patient and the consultant and the ITP MDT. So I look after patients that have failed or not responding to first-line or second-line treatment. I manage patients on rituximab. Generally, if the patients are on rituximab, I see them in the day unit. If I'm switching TPOs, they come and see me. They have to actually see me face to face when I'm switching TPOs, unless, of course, I know that they are actually going to do what I tell them. I can add immunosuppression, which is mycophenolate or azathioprine. And with consultation with the ITP MDT, we can try the triple therapy, that is a TPO plus steroid plus immunosuppression. In our MDT, we decide on whether or not we're going to try fostamatinib or sirolimus. And we look at the quality of life of the patient. The quality of life has become a very important part of our management of patients in ITP. It is at every clinic, somewhere along the line, you ask the patient how they're feeling. We're not asking how they're feeling when they walk in the door. We ask them, okay, tell me, how have you been? Have you been fatigued? How have you been? And generally they will tell me that they've been fine, they've managed to do lots more, and they don't feel as fatigued as normal. Or if they're feeling fatigued, I get an email and I then phone the patient and we have a discussion on the fatigue of the patient. And psychological support. I don't say that I'm a psychologist. I don't say anything about that, but I can support my patients and I can refer them to psychological support because our haemophilia centre is a psychological support centre now, and I can send them there. And I have a very nice patient that is a psychiatrist that does give up his time once every couple of months for me to talk to patients for me, that he'll come, when he comes for a clinic, he will, if I've got a patient that needs to have lots and lots of discussion, he will sit and talk to the patient for an hour. Next slide. The impact of for the nurse caring for ITP patients. Some patients, as I said, are admitted via A&E. We get to know the patient. We need to recognize the impact of the diagnosis. We have to discuss the course of the event versus long-term or short-term. We discuss the treatment options. And you must remember that the ITP patient is not the same. Every single ITP patient is completely different. I have to also stress when we're talking over here, the impact for the nurse. The nurse has to know what the patient is going through. The nurse can get so annoyed and despondent and almost traumatized when they're trying to figure out in the MDT, in advocating for their patients, and no matter what you do for that patient, nothing seems to work. And the nurse has extreme anxiety, and sometimes you can't talk to your patient because you can't face them sometimes because there isn't anything else that you can offer them. And all that you can do is go in there and just be honest with them and just talk to them. But I think sometimes there is a need for a nurse to have a debriefing session as well on caring for long-term patients. And I'm looking to get a few psychologists together and to have a meeting about how to look after a nurse caring for ITP patients. Next slide. We've gone through all the phases of the treatment, and all I can tell you is I don't look at the platelet count, I look at the bleeding symptoms. Our object in looking after ITP is maintaining the safest platelet count for the patient. It is to reduce the bleeding risk. One patient's platelet count of 50 can give them bleeding symptoms, but another patient's platelets of 1 will have no bleeding symptoms. And it is knowing the patient's safe level and minimizing everything and ensuring that the patients have a good education on their treatment. Next slide. Every stage of the ITP pathway, the patients need more or less input. When they get a new diagnosis, it is a very intense phase of lots of hand-holding and focus on patient platelet count. I can tell you the amount of times that patients arrive in my clinic with an Excel spreadsheet with their platelet count, and where you have to discuss. I've asked them then to go and tell me what their symptoms are at every platelet count. And we actually get to know when their platelet count is low. They phone me and tell me when they feel their platelet count is low. We have discussions on steroids and side effects and bleeding symptoms and managing their expectations. Our next period of hand-holding and being very good to the patients is when they fail the first line treatment. And you give them the other information, and you've got to manage their fears and expectations. When they get into chronic, they're actually more resigned to it, but they also need some support. But all of this is that you've got to remind the patient that you're there with them on their journey. You've got to remind them that you have MDTs and that there are forums for the patients to use. There is the ITP Support Association. For the nurses, there's the ITP Nurses Forum. For the doctors and the nurses, there's the ITP Forum. Please, please, please join all these forums, and remember that you are not alone looking after these patients. Next slide. As I said, little is ever said about the impact of treating patients with ITP on the nurse consultant. The nurses need a group that they can join to discuss their feelings and fears. They need information to be readily available at their fingertips to access what they need. We need courses and mentorship to allow us to develop ourselves and to ensure the highest possible standard and be able to deliver excellence in care. Sorry about those marks on that, sorry. Next slide. The challenges. In the pandemic, we had the challenges of remote working and follow-up. I found that remote working has worked quite nicely. The patients are quite enjoying having telephone calls, and we've instituted one law for them. They have to see us once a year, and they have to see us when they drop their platelets. Our other challenge is to prevent splenectomy, and our biggest challenge is something that I'm quite happy to say is getting more people, nurses, involved in ITP. Thank you very much for joining us tonight. Please, please, please join us again. There are lots of calls. There's lots of different series over the next week with the ITP Support Association. Please join us then. We've got an ITP Nurses meeting. I think it's on the 13th of October. And then there's the face-to-face nurses meeting on the 16th of November. Please. If you want the information, more information, Mervyn has got my email address. Please email me on the other meetings. Please join us there. The face-to-face meeting is the first face-to-face meeting in many years, and it'll be very nice to see a lot of patients and see a lot of nurses and to network. It'll be lovely. Up in London, unfortunately, we will do some more across the country over the next year. Thank you. Thanks, Mervyn.
Okay, everyone, thank you very much. As Louise said, if you need any more information, you know the email address of the ITP Support Association is info@itpsupport.org.uk. Please drop us a line if you need anything. If you ever need any more resources, leaflets, etc., please drop us a line. I put Louise's email address in the chat as well, so she's already said, like, you know, what you need to get hold of her for. So thank you very much. Let's hope we have another one of these again in the not too distant future. Thank you very much for taking the time to join us. It's a pleasure. Thank you.
Thank you very much, everybody.